So first of all, thank you for your kind invitation, and thank you to all of you for being here. Okay, so we are going to have two parts of this workshop. Just some theory in the first part with also some cases, practical cases, and then we have workstations. So we also had some real cases that we diagnosed, and so we can try to in the second part to perform some diagnosis together. You have ABUS experience already, or maybe the doctor, yes, you told before, and some of you normally uses ABUS in a screening setting or diagnostic and clinic. Never use it, but okay. So we have from 2 years this kind of new technology, and we have a breast care unit, and we are using this new device not only for screening setting in dense breast, but also in an oncological setting, because we noticed that we can have important applications also in an oncology center. And so we will see the possibility that we have. Normally, if we think about the normal ultrasound, so hand-handled ultrasound, we know that we use ultrasound for detecting breast lesions. Also, we can characterize breast lesions before biopsy. Then we can have ultrasound as a complementary tool to digital mammography or digital breast tomosynthesis to confirm finding, and of course to guide biopsy under ultrasound in case of suspicious lesions on mammography or DBT, cancers in dense breast, because we know that when we have high density, also in case of using digital breast tomosynthesis, the sensitivity is lower than in cases, for example, or A or B categories of breast. And then for the axilla, for studying the axilla. Of course, we have main limitations for hand-handled ultrasound represented by the operator dependency, of all of us know, of course, low standardization, and also considerable physician time for acquisition, because we, especially for the two breasts and the axilla, we need time to perform a very accurate and reliable normal hand-handled ultrasound. So the introduction of the automated breast ultrasound is important because this kind of tool was developed for a screening setting at the beginning. Okay, so to join the normal mammography to an automated ultrasound performed by the technician, and then we have a workstation with three-dimensional view of both breasts in order to perform diagnosis in case of dense breast. We use high-frequency transducers. We can have three-dimensional representation of the breast tissue. So also the possibility of, we will see later, possibility of reformatic images in 3 planes. So we use not only the axial plane, but especially the coronal plane. For us is very important. It's a new ultrasound imaging because it is the same of the surgical view. So for us it's very important. And then also the sagittal view. So all of 3 planes. Our device uses a supine type scanner because the patient is in a supine position. And then we have 3 different acquisition for each breast. So this is the linear transducer, and we have the transducer sliding over a membrane in contact with the breast, a specific lotion, of course, to avoid air bubble or artifacts at contact surface, and the patient in the supine position with arms above the head. This is for the right side, and the same for the other side. These are the 3 main projection, the 3 main ultrasound scans that we perform. As acquisition time, we have 1 minute, almost 1 minute for each scan, okay? And then the average total examination time is of 10 minutes. And after this kind of acquisition for each breast, we perform at workstation our diagnosis. We notice that the mean interpretation time is about 9 minutes for each examination, okay? So for us, it's very fast, especially if when you, after a bit of experience, we get more experience. For example, we will see later, we work a lot on a coronal view, and at the beginning it could be different, but then if you get experience, it's very easy and also fast to have the possibility of detecting lesions and also to characterize this kind of lesions. These are the 3 main acquisition that we will perform. The first one is the anteroposterior, then we perform the lateral view, and then from the external to the median part, and the internal view rotating the probe on the other side, so from the inner part to the subarachnoid region. Okay, if we have large breast, or for example, we need to perform additional scan, we can perform, for example, anterior, superior, or inferior, okay, if we are in case of large breast. We need to understand that the acquisition is very important, because it can also, basing on some artifacts that we can have during the acquisition time, we can have some artifacts. So it is important to avoid this kind of artifacts. So we need to know which kind of artifacts we can have. For example, contact artifacts. So it is important that during the automated scanning, there is a perfect contact with the skin of each breast. Then we can have this kind of lines that are represented by the probe motion, so we need to avoid this kind of artifacts during the acquisition, and also the subarachnoid region, because this is important. We have this kind of yellow point for each acquisition, indicating the nipple, and so it is important for us to have a good compression in this area, also for studying the subarachnoid region. That could be very difficult in case of not perfect examination or acquisition time. Already a lot of studies have been reported in the medical literature, in the scientific literature, and here we have this, that are the main experiences already published in the medical literature. As we can see, for the performance of this kind of tool, we have a sensitivity, a main sensitivity of 92% and specificity of 84%. So this kind of diagnostic tools are promising, and also if we compare with the hand-handled ultrasound in terms of diagnostic accuracy, we found no significant difference between EBUS and also normal ultrasound. So it is really a promising technique. We need to consider that we can have some false positive or also false negative cases. For false positive artifacts, we already saw the three main categories of artifacts that we can have: pseudo lesions, and of course we need a learning curve. This kind of learning curve, especially at the beginning from the operators, is important because it could be longer than the normal ultrasound that we perform. And also in case of false negative, they could depend from the peripheral location of some small lesions. So we need to be careful to the peripheral part of the breast glands, especially in case of large breast, and exactly large breast, the learning curve, especially at the beginning, and then the lesion size. Because as we can see, we have 97% of detecting rate after the centimeter, so for lesions more with a diameter of more than 1 centimeter, but we can have for 3 to 5 millimeters a lower diagnostic rate of almost 50%. And this is important. Yes, thank you.
What was your learning curve? Sorry to ask, because how long time did it take you to
we notice. Okay, no, we notice it is not so long, because depending on how many examination you perform for session. So at the beginning we had a lot of examination, especially negative cases, and so we had the learning curve of almost 2 to 3 months. Okay, so it's not, it's not enough, but it is important the beginning. So of course we need to perform always at the beginning the hand-handled ultrasound in order to compare your findings, and then also the mammographic reporting in each cases.
So you use it for all the patients?
We use at the beginning, yes, for all the patients. We have some problems, or okay, otherwise we can continue. No, it's okay. And so I think 2 to 3 months was our experience. Okay. For all patients, it will depend on the indication. So if you have a screening setting or an oncological or a clinical diagnostic setting. So for the screening setting was the first idea of this kind of ultrasound tool, because normally during the screening program you only perform mammograms. And so in case of dense breast, or also in all cases, you can perform also this ultrasound scan, and so you can have a report when you read also the mammogram. So it could assist you, for example, if you found an opacity, then you can define if it is a fluid, so for example cyst or fibroadenoma or other kind of lesions. So it is important because maybe you can reduce the recall from the screening. Our main use was in a diagnostic setting, because we perform, we are in an oncology unit, and so we are going to use this kind of ultrasound tool for a diagnostic setting. Of course, for the screening setting, especially in the dense breast, it is very indicated because there is an additional diagnosis of breast cancer. It has been calculated almost 2 cancers for 100 women screened, and it is not a great number because if you listen to our epidemiologists, it is not a significant value, because if you miss only 2 on 1,000, it is not so important. But of course, for us, it's important because in case of dense breast, or for example, C or D breast gland structures, it is important because you can diagnose 2 more cancers each 100 people. So it is, for us, is important. We have an increased total recall rate, an increased number, of course, of false positive, depending again on the learning curve at the beginning. Okay, this is important. We notice the different breast structures, so it is important for the detection. Again, we based on the study reported in the medical literature, and these are the main studies regarding the detection rate of abus in a screening setting. We will see later, but just already some cases for the detection. So usually we work on the coronal plane, that is this one, searching for black holes. So all lesions appear as black holes here. Then you can find the same black holes in the normal transverse plane that we use every day with handheld ultrasound. And so we can define the lesion that we detected on the coronal plane. Our use is this one. In the slides before, we talked about the mean diameter. Of course, we can find also 3 to 4 millimeter of diameter of lesions. So it is important because you always can identify the lesions on the 3 planes. And so if you only see one, for example, on coronal, and you find also in the other 2 sections, also in case of very small lesions, you can be sure that there is the presence of a new lesions inside the breast. So for the detecting, it is very important. Our applications were more than screening because we use in an oncology setting. Which kind of applications could derive from this automated breast ultrasound? First of all, the lesion characterization. When we found a lesion or a suspicious lesion, we know that today, also before performing the ultrasound guided biopsy, we want to understand which will be the aggressivity of that lesions, which will be, for example, the molecular subtype, because we know that some ultrasound features could be different basing on the different molecular subtype of breast cancer. So for lesion characterization, we can have more information and also a better standardization of this kind of process. Differential diagnosis between benign or malignant nodules, and then molecular imaging connected to the subtype of breast cancer. The staging, that is very important. We know also in case of lobular cancers, for example, we perform MRI before, for example, the surgical treatment. So in these cases, we are going to compare the diagnostic accuracy of MRI to the diagnostic accuracy of automated breast ultrasound, searching for more lesions or satellite lesions, okay? And we notice that we have very good values also reported from the abus. We normally use also as second look after MRI. So when you perform MRI, you have new lesions, you need to search in ultrasound. We know the problem of the changing from the prone position during MRI to the supine position during ultrasound. Also in this aim for a clinical setting, we can use abus because it could be less operator dependent, and thanks to the 3-dimensional view at our workstation, we can be sure that the lesion we found at the second look ultrasound is the same that we detected on MRI. And the last one, but it is the most interesting, we believe, the response evaluation to neoadjuvant chemotherapy. We know in case of triple negatives or HER2 enriched cancers, today we perform neoadjuvant chemotherapy before treating, before surgery. And so we need to perform MRI before starting the therapy and then after, or in some studies also during the therapy, in order to evaluate if the lesion is going to respond to therapy. And so in this case, also abus is very important. Probably in the future, we will not use the injection of contrast material as in MRI, but we can have a morphological view, as in this case with an automatic measure that could help us to evaluate this kind of partial or complete response to therapy. So we are very positive for the future in this aim, in our first experience. So lesion detection and characterization, staging, second look ultrasound, and also response to therapy. For our lexicon, for our diagnosis, we use, of course, the BIRADS categories and also the American College of Radiology, the same of the ultrasound, searching for masses or non-mass lesions. And it is very important, this new sign that has been also introduced in this lection, that is represented by the retraction phenomenon. This kind of phenomenon is normally detected on the coronal view, on our coronal planes. In our normal hand-handled ultrasound, we don't have this kind of plane, so it could be very difficult to diagnose the retraction phenomenon. For us, it's important because we use the coronal plane, because the EBUS can provide us, for our diagnosis, this kind of detection. And it is important because this is highly suggestive for malignancy, and at the same time for breast cancers with a favorable prognosis. So for luminal cancers, we usually don't find the retraction phenomenon in triple negative or A2 enriched cancer, but in luminal A or B cancers. So it is suggestive for malignancy, but at the same time, it has a better prognosis as compared to the other signs. So for us, it's important not only for the detection, but also for the characterization. This is the category that we follow. I think that all of us know this kind of standardization for mass lesions, and it's very easy. I told you we will see later. For mass lesions, it's very easy because we found the lesion, we can find the masses. So maybe it's also during the learning curve, is the first step is very easy, depending also on the size of lesions, but it's not so difficult. Coronal plane, again, is the same of surgical view. So for us, it's very simple to identify. This was also our experience because today we can identify also DCIS. So before, we only had microcalcification on mammogram, etc. With the high frequency normal ultrasound, but also with EBUS, we are able to identify also the CIS, because on the coronal plane we can better identify, for example, microcalcification foci, and also the possibility of finding hypoechoic areas. The very interesting area of lesions is represented by the architectural distortion, because compared with the mass lesions, these are more difficult to identify on normal ultrasound. Again, thanks to the automatic scanning and the coronal view, we are able to better identify this kind of lesions that are defined as hypoechoic areas without associated mass. And so these, for example, are the most target that we need to identify in EBUS, because normally we have non-oriented hypoechoic area producing distortion of the normal breast parenchyma, normal breast without developing a real mass or a real nodular lesions. Okay, they are important because they could be DCIS again, as I told before, but also lobular cancer. So it is very important. And in the detection of architectural distortion on the coronal plane, of course, EBUS has a better performance, a better diagnostic accuracy as compared to hand-handled ultrasound. These are all examples, as you can see, of retraction phenomenon. Of course, we need biopsy in all cases, because there could be also, for example, B3 lesions, for example, radial scars, or for example, sclerosing adenosis. So we are not telling not to perform biopsy, because biopsy is mandatory in all cases. But when we find this kind of lesion on tomosynthesis, sometimes in normal ultrasound could be difficult to identify, but with EBUS we are going to exactly detect the lesions, and then we can later also found in normal ultrasound, because we know exactly the, for example, quadrant of the breast where they are located as lesions. Yes?
So when you find out the lesion of the EBUS and you see the patient is biopsy, do you call her back later, or you take her to another room and do the biopsy straight away? Or do you do the biopsy under the...
No, we don't perform the biopsy under the EBUS, okay, because you need to compress the gland during EBUS, and so the EBUS is only 1 minute for each scan. But with the three-dimensional view, the use of cursors, and also the three planes, we, of course, we know where it is located, and so we have a second look with normal ultrasound. We notice the lesion, and then we perform biopsy. So this is our setting, and it's very, very easy to perform. Okay, of course, if you don't find, you still have the stereotactic way for performing biopsy, because if you see on DBT, you can perform with a DBT guided biopsy. These are the main features that we need to know for differentiating benign from malignant lesions also in EBUS. Of course, the lesion type, and so mass lesion or architectural distortion or margins. The lesion shape is very important. Okay, and the presence of retraction phenomenon, because this phenomenon is highly suggestive for malignancy and again for luminal cancer. The echoic halo around the lesion, and then very important, the post-acoustic features, as already appears for normal ultrasound, for hand-ended ultrasound. Okay, because if we have, as we see here, shadowing, so of course it is highly suggestive of malignancies, but we also need to be careful because all triple negatives with not so good prognosis, they don't have shadowing, but they could be also enhancing on posterior view. And so it is important because this kind of, we will see in molecular imaging, this kind of features in shadowing could be useful for differentiating from luminal or, for example, triple negative cancers. So it is important. And then the presence of calcifications, because as we already saw before, we can easily find also small clusters of microcalcification inside the nodule in the coronal view. Just for anticipate something, in the future we will see at the end, we could also have artificial intelligence applied to this kind of imaging for CAD system, or also for machine learning or deep learning that can be useful for the interconnection of all the kind of features, and then to have also an aid for our diagnosis and for our differential diagnosis. For the staging is important because for the tumor size, we know that when we are going to stage lesions with MRI useful, we can have higher size as compared to pathology. For ultrasound, it could be difficult because sometimes the lesions has a vertical development, and so it could be very difficult to have the two dimension. So in case of automated breast ultrasound, we notice good concordance with the pathological results in terms of tumor size. Also with the lesion size on MRI. Of course, in MRI, useful they could be appear with a higher size as normal, and also as normal ultrasound, and also EBUS, correlation with pathological lesion size, and also with the extent. These are some examples in multifocal disease or multicentric disease. Of course, we start in all time with the coronal view, and then we search for the black holes, and also with other lesions. And it is important because we have good diagnostic performance also for satellite lesions of less than 1 centimeter, because we can find also 4 to 5 millimeters of size for additional lesions. The T size is important because we have standardization, so less operator dependent as compared with normal ultrasound for measuring the lesion. Then we can find multifocal or multicentric disease that is important for the future surgical planning of the patient, okay, so for conservative or for mastectomy. And then bilateral disease, because in all cases we have bilateral acquisition also with automated breast ultrasound. And it is important because if we know that we have this CIS also after biopsy, this kind of tool could help us to find some features that we saw before for searching invasive cancer. Or on the contrary, if we already know that we have an invasive cancer, it could help to us to evaluate the extent, for example, or the presence of in situ component, so the CIS evaluation. So for both the type of cancer, also in oncological settings. This is already, I don't know if we have later, but we also have some cases for detecting. This was a case of course, dense breast, not for screening, but for normal clinical evaluation. And we have round opacity here. As you can see, they are fluids or normal cysts, but in tomosynthesis, we notice architectural distortion. So on the coronal plane, as for tomosynthesis, we notice the presence of the lesions just around the benign cyst. Okay. Then when we have the visualization of retraction phenomenon, we can identify also on the transverse plane, on the sagittal plane, and we can detect the lesion and also define the lesion, because as you can see, we have irregular edge, irregular shape, some also small microcalcification inside, but this was just an example where the coronal view is completely almost the same of the view that we have on the tomosynthesis slice, on the DBT slice, for the evaluation of the extent. The other application was the second look ultrasound after MRI, searching for satellite lesion again, and so we have the similar performance. Probably it will be also better performance, because also in this case we have less operator dependent tool, okay? And for detecting this kind of lesions we need to, yes?
Second look, it will be targeted ultrasound, or will do the whole breast?
If we, thank you for your question. First of all, if you already have an abus before MRI, we can just reevaluate the images without performing a second abus, because it will be the main advantage is that you can study images all time, also in a retrospective view. So after MRI, if you already have abus volume, we can reevaluate the volume without performing new abus to the patient. Otherwise, if we perform abus, it is better to perform the two breast in all cases, because for us it's important in some cases, if you have artifacts, to compare one side with the other side to be sure that that satellite lesions already exist in the breast. So the suggestion is to perform all the time the two breasts. In our cases, maybe we have some cases also here for neoadjuvant chemotherapy when we already have a volume and then we perform MRI after therapy and abus again, we can perform only one side because the other one was already acquired before the therapy, for example, 2 or 3 months before. Okay, thank you. And then this was the importance, because we know that for the second look ultrasound, we need to move from the prone position during MRI to the supine position. So this is very important because we know that we can have a rotation of lesions. We also performed a study evaluating the rotation from the upper median region to the outer or the inner part, etc. So it is very important because with an automatic scanner by ultrasound, it could be easier to find satellite lesion, and so to avoid, for example, MRI guided biopsy that we know that could be difficult and also time consuming. And these are some examples. Of course, you have also some technical advantage because we have a curved plane with a very high possibility of contacting all the surface of the breast you want to study after MRI. And so in these cases, for example, what do you think? They are benign or malignant lesion in this abus coronal view? When during MRI we find mass lesions or with a diameter ranging from 6 to 8 millimeters, and then we performed the abus on the coronal view. First of all, we have all mass lesions, and then if you consider the shape and also the edge, they are all regular, and so they were benign lesions with fibroadenoma, of course. Yes. The last part in an oncology setting for us is very important is the evaluation of response to therapy, because we know that during MRI we can use also diffusion and DVI, but you still need, if you consider the standard protocol, to inject contrast material. And so we are performing this study comparing, we have already 45 cases comparing MRI to abus, and we are really positive for the future because we are not noticing any difference in terms of response evaluating without injecting of contrast material. Of course, you need the first volume, you need a time zero abus examination before therapy, and then it is easier to compare because it is less operator dependent. You can have a very accurate measuring of the diameters on the coronal, sagittal and transverse view if you have a correct examination, and it is important. These are some cases, and also for the sensitivity and specificity for the prediction of complete or partial response, we have value ranging from 80% and for in terms of 88 for sensitivity, and the specificity also as also happened with MRI, we have small lower values, but it is the same problem of MRI for specificity. And also for the literature, it is already been demonstrated that we can use this kind of tool for the early prediction of response to therapy, comparing. It is important because for molecular imaging is strictly connected. We need to know this kind of classification. It is important because luminal A or the first one, sorry for some Italian, of luminal B could be with a good prognosis, but this kind, so non-luminal, HER2 enriched or triple negative, need to be identified, and we can also try to characterize the lesions before performing the ultrasound guided biopsy. Yes. For example, the HER2 enriched are characterized by very similar to triple negative, but they contain microcalcification, while triple negative have round or regular edge with enhancing posterior, so not shadowing but enhancing, without microcalcification, and normal they have larger size as compared with HER2. So all these features are very easy to detect with also ABUS. This is an example of a lesion. What do you think? Of course, it is not a dense breast, but we use the same ABUS ultrasound. It was before the beginning of therapy. Which kind of histotype you think it could be? It was a young lady, yes, not so. And it was a triple negative. Also on mammography, we have oval or round, okay, with 2 centimeter of diameter. We perform biopsy, and of course, you also use the marker inside the lesion, because after the therapy, if you have a complete response to therapy, and so you want to perform conservative surgery, you need to locate the lesion after the therapy, so the presence of the marker is very useful for this kind of location. So this was the mammogram. This was the same case tomosynthesis, okay? So the slice where we can find the upper inner part. This was MRI before. So in this case, we can perform also one side because the other is completely negative, but we prefer to have at time 0 both breasts. Also because in an oncology setting, the patient will come in the next 6 months or years, so you have already a volume for evaluating also the follow-up of the patients in the future. DVI also, I don't know if you also use DVI with eye signal, and if you have ADC map, the ADC is very low inside the lesion, so very easy to understand it is malignant, and this is the ABUS. You need to get used, but this is the normal, this is the nipple, and this is the lesion. And the coronal view, and here you have the transverse view, the axial view. Okay? After the therapy, do you notice some difference, or it could be difficult? We have a complete response to the therapy. So this was the lesion before, and this is just the site of our marker that we performed. And maybe here, just a moment. Okay, and so this is the marker. If you identify, you have the hyperechoic part that we located inside the lesion with the fibrotic area, that is the shrinking of the lesion after therapy. Okay, so this was the part, and we had the conservative surgery. So if you, after the learning curve, it could be very easy to understand and to measure the response to therapy, also in an oncology setting. This is another case, could be difficult, but I prefer also to have here because it was located in the very inner part, okay, of the breast. So maybe the peripheral part could be difficult to be evaluated with ABUS, but in these cases we knew the lesion. So this was the time 0 lesion here, and the coronal plane, and again the transverse plane. Okay, here in the inferior part, median inferior part, and here you have the transverse scan before therapy. This was MRI. Of course, we follow the standard protocol, so we perform ABUS, but we still perform MRI in all cases because you can miss something. So this still, it is not like the previous case. We still have disease confirmed on MRI, and also on abus inside. Another case, of course, advanced disease, inflammatory cancer, so chemotherapy also in this case, MRI before and MRI after therapy. And this is, we also had benign lesions, okay, in fibroadenoma, because also in this case we have a young lady. This was the lesion before with a very important retraction phenomenon. This was the partial response to therapy. We can evaluate with less operator dependency the size of the lesion to the different molecular histotypes. So if you notice the retraction phenomenon, as I told you, it has been correlated to luminal cancers, for the post-acoustic features enhancement for triple negatives, for the irregular luminal cancer with better prognosis, etc. Okay, and this was the same for the different histotypes. Okay, so HER2 enriched because we have round shape and microcalcification. In medicine, not always so easy. Again, biopsy is mandatory, but is important. And the first one, retraction phenomenon and luminal cancers. If Jamie agrees, of course, we need to talk also about some cons. So also axilla or inflammatory fold or supraclavicular space. Conservative surgery, we can have, for example, fibrosis. So in an oncology setting, in the follow-up of patient, we can have some problems for evaluating the scars, but it is the same problem that we have in normal ultrasound sometimes. Of course, lack of color Doppler ultrasonography, and we need to prepare our technicians to perform abus because the examination need to be perfect to have a very good diagnosis, reducing the artifacts that we saw at the beginning. And of course, imaging interpretation training more than the other. The future will be to join the abus features to the artificial intelligence. Deep learning, no more with machine learning, so we have the possibility of using neural networks, and so maybe also this volume deriving from abus could be used with artificial intelligence and deep learning for tumor classification or for tumor detection or for differential diagnosis. And these are some examples reported by using convolutional neural network, where we, in this case, is the medical doctor is completely sometimes passive because all the software and the neural network is going to perform a response.